Hi, everyone. My name is Ankur Gupta. I'm a general dentist. And if I had to describe myself, I would describe myself as a general dentist who's pretty conscientious, who tries my best, but is very much imperfect. And after being a general dentist for almost 20 years, what I have found is there are so many clinical elements that have just made me miserable. But along with being a general dentist, I'm also an educator. And by being an educator, I constantly have the opportunity to interact with other dentists who are also educators. And these other dentists are not like me. These are people who are incredibly well researched, they're incredibly talented, and they do the most cutting edge and special type of dentistry. And all I do when I rub shoulders with these individuals is I ask them, what do you do? What are the procedures, the techniques, the products, the supplies that you use? What are the things that you use that make it so that your dentistry is so successful? And over the years, I've learned a lot. And the whole point of today's lecture is to make it so that you can benefit from some of the things that I've learned as well. I want to thank the sponsors. The Dental Products Report is the organization through which the platform that I get to address you all. So a big thanks to them. Catapult Education is a speaker education bureau that allows people, all dentists, to learn from some of the smartest people about general dentistry and different dental techniques and whatnot. So, for those of you who've never heard of Catapult Education, I would recommend that you visit their website. It's catapulteducation.com. And Bisco, who is the main sponsor for this event, Bisco is a producer of several highly innovative and sophisticated dental products that I'll be showcasing throughout today's lecture. But I'll be showcasing a whole lot of products that I use that have made my life easier. Some of the Bisco products are my favorite, but I'll be showcasing quite a few products that are competitors to Bisco as well. I want to make this as transparent as possible. Before I get started, I do want to let you all know that if you go on my website and you click on the handouts tab, I do a very good job of creating extremely high quality handouts for my lectures. And I want to make sure that all of my handouts are free to the public. That means that if you were to go to my website and you wanted to download any of my handouts, whether it be about implant overdentures, about practice management, whatever it is, you can do so without giving me your email address or signing up for a subscription or a membership or anything like that. I want to make it so that every dentist can just be a little less miserable, and it'll bring me a lot of satisfaction knowing that these things are available. So here are the rules of general dentistry. At least this is the way I was taught when I was in dental school 20 years ago, early 2000s. The rules of general dentistry. Here we go. Ready? Blood will ruin everything. Even though blood is in pretty good supply inside of the mouth, it'll ruin everything. It'll ruin your dentistry. It will ruin your prep. It will ruin your vision. It'll ruin your scan. It'll ruin your impression. It'll ruin your cementation. It'll ruin your bond. And second to blood is saliva, which will also ruin everything, but just not as much as blood. And then, of course, failed dentistry of any kind. So if any of your bond or impression or cementation were to be ruined by blood or saliva, it is all your fault. And if you miss something like decay or stain or a void, well, then you're a failure at life. If a patient has sensitivity after you worked on a tooth, you are a terrible dentist. If a crown that you did came off, you are a horrible person. If the margins of your restoration have a brown stain, your spouse should leave you. Now, what I want to do today is give you tips, techniques, and strategies so that this happens less. But I will tell you that if any dentist tries to claim that these things never happen to them because they use all the best techniques and they are so conscientious, they are probably lying. All of us as dentists are subject to the fact that life is life. And some of this stuff does happen. And I would encourage all of you to look at your own profession and the way that you and the mistakes that you make or the things that you learn with grace. And always try to treat yourself well, even when things that you try so hard to do well don't work out. So let's talk about one of these things, okay? A few years later, your restoration looks terrible, or a patient says it wasn't really hurting until you worked on it. And I want to start with these three. And these are all of these are mine, sadly. Dental implants that for which the patient is starting to lose bone and lose tissue height around their implants. If they live long enough, they're going to lose their dental implant. Or the case on the right, where I did a restoration, those kissing class twos that I find very difficult. And now the patient comes back, and my hygienist tells me, "Oh, Gupta, she's doing great. She's doing such a great job with home care. I took care of her entire mouth, and there was no bleeding. Oh, except for that one filling or that one crown that you did." And if I'm going to talk about these things, what I need to first talk about is the fact that these people needed an implant for a reason. They needed a denture for a reason. They needed a kissing class 2 composite for a reason. And that reason is that somehow bacteria was allowed to thrive in their mouth. Wouldn't you agree? If you're thinking about that, like, does he have a point? What I'd like to ask you is, how many of you are going to go the rest of your entire lives without losing a tooth? And the answer is probably a lot of you. A lot of you feel quite confident that you're not going to lose a tooth. Even further, a lot of you, including myself, feel confident that you might go the entire rest of your life and only get one, maybe two cavities for the rest of your life. And that's because all of us have developed certain home care routine habits. We have maybe better luck than the average person when it comes to the overall makeup of our saliva. We have eating techniques or eating habits that make it so that bacteria can't thrive. Yet all the patients in this picture, bacteria did thrive. And as dentists, we were there to try to fix whatever damage occurred because of that bacteria. So I graduated in 2004. So I've been a dentist for almost 20 years. And I look at this, and all of these things were recommended. All of these things were recommended for patients that need dental work. Oh, look at you, patient, you need dental work. So I suggest that you brush, floss, use floss picks, use a water pick, use antiseptic mouthwash, both over the counter and prescription. Make sure that you come into my office very often so I can use sharp instruments and piezo scalers and rubber cups and superfloss and iodine and antibiotics. And the fact is, that is so unbelievably unpractical. Nobody spends that much time taking care of any part of their body. Why would we expect people to quit their jobs and just brush and floss all the time? It's a very stupid expectation. So let's talk about what are the things that we should be emphasizing more so than other. And most of you are probably thinking about the big three: brush, floss, see your dentist, right? Brush, floss, see your dentist. Those are the big three. I feel like we all kind of are members of the church of brushing, flossing, and seeing your dentist because we were told that over and over and over again. And then all of a sudden, in 2019, in the Journal of Periodontology, this study came out. It was a meta-analysis. So it was a study of several other studies in which basically, as an adjunct to toothbrushing, all of these things like a floss pick and flossing and water flosser, etc., were tested to see which is the best at reducing gingival inflammation. And amazingly, interdental brushes, which are those soft picks that you see on the upper right, and water jets, which I call a water pick, those rank the highest for reducing gingival bleeding. Floss ranked last. Now that's a big deal because I'm a member of the Church of Floss. I've been telling people to floss my entire career. Maybe what we should be recommending to patients should be more in line with what is scientifically most up to date. I believe that when I recommend expensive dental work on patients that already have poor oral hygiene or poor oral history, that I should be recommending that I should be either giving them a water pick or at least highly encouraging them to use a water pick. Secondly, in those little goodie bags that we give to patients, with the toothbrush and the little pack of toothpaste and the floss, maybe I should be throwing in a pack of these soft picks because they are more effective. I just didn't know about it before. These are things that I wouldn't have known if I wasn't an educator. But more than that, I want to be able to take a patient who's had just garbage for teeth their entire life. People who are chronically gross. You have them, I have them. People who they have gingival inflammation every time I see them. They have cavities every time I see them. Their gums bleed every time I see them. There's plaque all over their lower anteriors every time I see them. And I want to know, what can I offer that won't damage the implant or the tissue or the root or the surrounding bone, that is not painful and invasive like our piezos and our curettes? It doesn't rely so heavily on the dexterity of my hygienist, who already works so hard. And sometimes it's very unreasonable for me to expect them to completely remove all the plaque and tartar from a furcation or from certain areas of the mouth that are just hard to get to. That allows for a patient to regularly comply, even though that patient is an imperfect human themselves. They have limitations in their dexterity. They may not be very disciplined. Even though you and I brush and floss and use water picks every day, maybe that's something that's a little more difficult for them to add to their routine. What is something that I can do that won't leave a plastic residue on a dental implant, that's affordable for both me and the patient, that's not an antibiotic and still kills bacteria? And it wasn't until a couple years ago that I discovered these things. But this is like performing a magic trick. These are perioprotect trays. That's where you take a scan or a nice impression. You also do a perio chart, and you submit your scan and the perio chart to their lab. Then what they do is they fabricate these very sophisticated trays that are designed to take whatever medicine you put inside of those trays and deliver that medicine deep under the gums, wherever that bacteria might be. It just gives me an opportunity to provide the patient a means of not using any dexterity, just slopping some trays in their mouth that'll deliver medicine. Now, let me tell you how hydrogen peroxide works. It's actually quite easy. Hydrogen peroxide, when it gets delivered down into the sulcus, it converts to oxygen. That's all it does. Hydrogen peroxide goes into the sulcus, it converts to oxygen. Well, who are the bad guys in the sulcus? They're gram-negative anaerobes. Gram-negative anaerobes, they thrive in a non-oxygenated environment. And so all that's happening is these trays are delivering oxygen into the sulcus. And they're so easy for patients to wear. So what I have found is that patients who've been coming to see me for 20 years almost, who've been gross at every visit, all of a sudden they're not gross. I'm making it a point to, whenever I feel like, boy, all this dental work that I'm doing, I'm going to be pretty miserable if I do all this dental work and 6 months later it's all falling apart because this patient is so gross. This is a way for me to feel a little less miserable, because if a patient complies, that dental work that you did is going to last a lot longer. And this is very easy to comply with. Second thing I wanted to talk about is just times in which we did a crappy job. This picture on the left is probably what happened was I didn't remove all the decay. Or what also could have happened was I removed all the decay, but I did a super crappy job bonding the composite in there. Either way, there's decay underneath that composite, and I feel crappy. On the right side, I feel crappy because I made that patient a crown that didn't fit along those margins. The simple answer is I should have taken an x-ray the day that I seated the crown. And that was a failure of thoroughness on my part. But more interestingly is, what could I have done to have made sure that that crown would have had beautiful margins at the time, so this problem wouldn't have happened. And I want to first start by talking about a root canal procedure that I did 2 years ago when we first hired an associate. So my wife and I were getting old, and we hired an associate. And the associate said, "Doc, I don't do molar root canals, but I want to learn." So I was doing a molar root canal, and she said, "Can I watch?" And the two of us had this stupid, awkward thing where she was sitting on the other side where the assistant normally sits, and I'm holding my mirror, and she's trying to get her eyes to see what my mirror is seeing. And I said, wait, stop. This is stupid. Let's get out the intraoral camera, and I'll take pictures, and that picture is going to show up really big on the screen, and we can look at the procedure together. So I did my access, I took a picture, and we both looked and said, "Oh, wow, there's crud still in that distobuccal canal." So I started cleaning it out. And this is the weird thing that happened. There was crud in that distobuccal canal. I cleaned it out. I started feeling kind of good about the procedure that I was doing. And all of a sudden, the two of us noticed that. Now, I've been a dentist for 20 years. I don't normally find the second mesiobuccal canal in a first molar. It's just because, I don't know, maybe I'm just not a good enough dentist. But in this case, I did. And it wasn't because of my skill or my age or my experience. I found that distobuccal canal because the camera magnified what I was looking at so much. All of a sudden, that picture was giant on my TV screen, and I was able to instrument that second mesobuccal canal and do much better dentistry. Now, I know some of you are like, "That's cool, doc, but I don't do molar endo," and that's fine. Why don't we talk about this one, where I was doing a crown prep? Now, in this case, before I discovered this magic of the intraoral camera, I always just used the intraoral camera to educate patients, to show them their big amalgam with a fracture through it. I never used the intraoral camera to check myself, but I started getting into it. So I prepped this crown, and I was like, I'll just take a picture of it. I thought I did fine, but I left this kind of brown, gross stain right at the margin of this crown. So I took a slow speed handpiece, I buzzed it all off, and then I was able to continue doing dental treatment that I'm proud of. This is a very clean tooth. It's going to be a successful restoration. What's interesting is I could have missed that decay. I would have missed that decay. And the reason I was able to find it was not because of expertise or experience. It was because I took a moment to take a picture with an intraoral camera. I got one more for you. So this was a really difficult procedure. The patient had an open margin under an old crown. I popped the crown off, and I saw like all this decay. It was under the gums. I busted out. I removed all the decay. I filled it with like a glass ionomer filling. I had to use a laser to cut away the gum tissue. I was able to get a clean margin. And I was like, man, I'm proud of myself. Let me take a quick picture. And I missed a gigantic chunk of cement from that original crown. How did I miss it? I don't know. But a bunch of you are probably judging me. You're like, man, he must be a bad dentist. I'm telling you, when I was doing this procedure, maybe I was focused so much on that mesiolingual, I just didn't notice that large chunk of cement. I took the picture, I took my Explorer and just pinged it right off. And then I was able to do dentistry that I was proud of. Here's the rules of an intraoral camera. Buy one that is cheap enough that you can have it in every operatory, and buy one that's simple enough that even your most untech savvy dental assistant can still be snapping photos left and right. Now I want to talk about patients that complain that something's hurting after I worked on it. And I realized this is a really painful thing. I really try my best to remove all the decay, to bevel my margins, to use a highly rated bond, to pack a composite in there that is highly rated. And then when the patient comes back and is like, hey, doc, it hurts. I can't chew on this side, or I can't eat cold, or something like that, I feel so discouraged. And so let's talk about this. And I want to break it down into the big rules when it comes to composites. And that is etch, bond, the actual composite, blood, and heat. Let's start with etch. So the thing about etch is that if you blob that super powerful acid close to the nerve, the patient's going to be sensitive. And I always thought, because I graduated in 2000, I always thought that you're supposed to etch the crap out of the tooth and that's going to create the best bond. What I found much later in life is that if you etch the crap out of the tooth, you are going to set yourself up for a higher potential for sensitivity. So what you should be doing instead is selective etching. Keep your etch away from the pulp, but etch very thoroughly the enamel that you beveled. If you do that, you're going to get a great bond to that unetched dentin and a great bond to that etched enamel. The only key here is you have to buy etch that is flowy enough that you have control so it doesn't just bloop all over the place. Now, I use an etch by Ultradent. I think it's called Ultra Etch or something like that. And the reason I use it, I don't know if it's a better etch. The reason I use it is that it's controlled. I can selective etch very nicely using that etch. And if I do this, I'm not going to create sensitivity by etch, but I can still create sensitivity. And let's talk about bond. Okay, and I want to talk about 4 things. Number 1 is sometimes a lot of there's a lot of different types of bonding agents that are out there. There's a lot of salespeople that say that their bonding agent is the best. If you want to have maximum bond strength, you have to etch if you want to have maximum bond strength. Now, you don't have to etch the dentin. You can just etch the enamel, but you have to etch. Now, there's plenty of bonds that are out there that say, yo, man, our bond is great and you don't have to etch. And that is true as long as you follow a couple rules. Number 1 is sometimes if there are enough walls in your prep, meaning that you have mechanical retention in your prep, you don't really need to have the best possible bond. You don't even have to etch. I use a bond, universal bond. It's by Bisco, who's sponsoring this event. Bisco's All Bond Universal. I still etch, but I've been told by Bisco that etching is great and it will strengthen the bond, but it's not always necessary. But what I have to do when using a universal bond like that, whether I etch or not, is that I have to make sure that I follow the manufacturer's instructions when it comes to scrubbing times. And scrubbing sometimes is 20 seconds. And I have observed enough dentists not scrubbing for nearly as much time. By the way, that 20 seconds that I just said, that's arbitrary. All of your manufacturers are going to have different scrubbing times. So if you have walls, it doesn't really matter what bond you use. If you have walls, use whatever bond you find most convenient. The bonds that seem to make it at the top of the list over and over again are the bonds that you're probably thinking of. Scotch Bond by 3M, Peak Universal by Ultradent, Bisco's Universal Bond, Optibond. It doesn't matter. They're all so good, but you just have to make sure you follow their recommended scrubbing time. However, there are times when you have no mechanical retention, where you're literally trying to bond composite onto a flat surface. There's no mechanical retention. And in cases like that, you need the bonding agent that comes up in studies in which there's no conflict of interest, meaning studies that are not sponsored by any particular company. And the 2 bonds that come up as the strongest bond in areas with no mechanical retention is Optibond XTR and Peak Universal Total Etch Bond. Okay, those are the best ones. Do I use those all the time? No. Actually, I don't use them much at all because they're more expensive. I like my bonding agent from Visco, so I use that one for the most part. However, if there's no mechanical retention, I'm going to use the bond that has the highest studied bond strength. Now let's talk about composite. And I think for the most part, we just want a composite that's not going to annoy us as we're packing it into a prep. However, most of you need to know that there's a type of composite that exists called bioactive composites. Bioactive composites are composites that basically, after you cure them and the patient goes home, these bioactive composites are constantly releasing minerals, and those minerals are bacteriostatic at the interface, at the cavo-surface margin, meaning where out in the mouth they're releasing minerals that are bacteriostatic, so you're going to have really nice clean margins. And close to the pulp, they're also releasing minerals, so they kind of act as a liner. They make it so that the pulp is a little more comfortable. And what I really like about these bioactive composites is they behave like regular composite. I mean, if you can see this video down here on the lower right, this is just composite. It's not like, it doesn't behave especially different. And so I like it just because it's easy to pack, it's easy to adapt, it's easy to shape, it's easy, just like lots of composites that are out there. But what's nice about it is that it's going to be bioactive. It's going to make it so that my margins are going to be a little bit cleaner, and that anything that's close to the pulp is going to be a little bit more pulp friendly. The bioactive composite I use is made by Shofu. It's called Beauty Fill. However, there are other bioactive lines that are out there. I think Vista Apex has come out with a bioactive composite. More than likely, it's quite easy to use. What I would recommend you do is get a couple of different types of bioactive composites and see which one you enjoy the handling of more. Now we need to talk about heats. And I feel like we forget how absolutely barbaric our jobs are. We are taking a drill, a sharp metal burr, revving it up to 20,000 RPM, and we're pulverizing the enamel and dentin in a person's tooth. Just think about that. We are taking a drill and pulverizing an incredibly hard substance. And when you do that, you have the potential of creating a tremendous amount of heat, especially if the process of pulverizing that enamel, of completely obliterating that enamel, if the process of obliterating that enamel is inefficient, you're going to create a lot of heat. How does it become inefficient? Well, first of all, it's inefficient if you use burrs that don't cut that well. Now, I've been using carbide 330s ever since I graduated dental school. Then I was giving a lecture, and Premier Dental was there, and they said, "Here, try these 2-stripe diamond burrs." And it's kind of shaped like a 330. And I started using them, and I swear I can't imagine ever going back. These things blast through the tooth. They're so much more efficient. I drill for a shorter amount of time. It's more pleasurable for me. But what's more important is that we're not creating the amount of heat when we're struggling to cut something away. Now, the second thing I want to talk about is I want to encourage all of you to at least consider at some point in your career to invest in an electric handpiece. An electric handpiece cuts so much more efficiently. You know, I'm sad about this video because my electric handpiece, this is by NSK, it's so, it has such an awesome light that comes off of it, but it makes my video harder to see. But anyway, this lady, she had a bridge. It was a 4-unit bridge, and the metal, the PFM, the metal part of the PFM was that old kind of stock base metal that is like so unbelievably difficult to cut through. And I was able, now I used a carbide 330, cut through the metal, but using my electric handpiece, I was able to cut through that using 2 burrs, which is crazy. I mean, when I was using my traditional air-driven handpiece, it took me like 7 burrs to cut through that base metal. This makes it so much more efficient, and you don't generate as much heat the more efficient you are. And then the last thing I got to talk about is blood. And there are so many ways in which you can overcome the blood problem. So here I have this class 5 composite. And I know that once I start removing some of that enamel, that there's going to be decay under the gums. And that if I remove that decay, I'm going to nick the gums. Now, this is a problem because I already nicked the gums here, and I'm not confident that I've removed all the decay. There's still kind of that brown line. You see that right along the margin, the gingival margin, where it could still be decay, but I'm too much of a weenie to go at it. Now, some of you might be like, well, can't you just pat cord? And my answer to that is, hell no. I hate packing cord in areas like this because I'm so worried that my slow speed handpiece is going to catch one of the fibers of that of that cord and pull the cord out, and then I'm going to be in a total bloody mess. So what I would recommend you think about at some point in your career is investing in a diode laser. What it does is it cuts gum tissue without bleeding, which is so incredibly liberating. It cuts away gum tissue without bleeding. It eradicates bacteria in the area that you're working. And if there's an area that's already bleeding, it eliminates that bleeding. So for that tooth that I was working on, I just used my laser and I cut away all the gum tissue that was close to that gingival margin. Of course, I kind of burned some of the tooth in the process. That's okay. I just used my slow speed handpiece. I removed anything that I thought might have been decay, any of the burned tooth structure. Now I'm looking at that thing and I'm thinking, there's no decay in that tooth anymore. There's no decay and there's not a drop of blood. I can restore that thing feeling like I'm a good dentist, where that patient is most likely not going to have any issues. And in 10 years, I can look at that composite and say, man, because I beveled, because I etched, because I used a highly rated binding agent, and I actually followed the manufacturer's instructions, because I did so without any blood, that this restoration is most likely going to look like this in 10 to 15 years. Oh, and the fact that I filled it with a bioactive composite. Doing all of those things makes me feel like I'm actually a good dentist. It makes me feel a little less miserable with my career. Now, I use this laser quite often. Here, patient had a huge cavity. I just use the laser. I made it so that I could see. If I tried to start removing decay, I would be stuck with a bloody mess. Now I can see everything that I need to do. Before I even put the rubber dam on, I know that I'm not going to deal with a bunch of annoying blood. The problem with a laser is that it still hurts. I mean, you're still cutting gum. So the patient is still going to hurt afterwards. And I only have 2 lasers in my office. I have 8 operatories. Sometimes I need a laser and there's not a laser in my operatory. So then my assistant has to get up and she has to get the laser and set it all up. That's still time consuming and annoying. And I don't want to go through that time when I have just a little bit of blood where I'm like, do I really want to bust out my laser? Maybe it's in the room, but I'm feeling kind of lazy. Look at this picture down here at the lower right. It's a nice crown prep. I feel like everything's done. I'm ready to do the scan except for that mesiolingual, that little bit of blood. I don't want to bust out my laser. It's too time consuming. And so what do you do in this? You can use cord, but cord is also painful. It's very barbaric, jamming cord underneath somebody's gums. You could use viscostat, a liquid material that would stop bleeding. And that's great, but it doesn't do anything to retract the actual gingiva that's along the margin. Or you can use a gingival retraction paste. And I love gingival retraction paste. This one here that I'm showing, this is a gingival retraction paste made by Voco. I think it's just called gingival retraction paste. What I like about this particular material is that I don't use a comfort cap. This stuff, I think it like expands and hardens or something, but what happens is after I wash it off, there's almost like a little moat, a little space between my margin and the gingiva that's created by this gingival retraction paste. And I find that really helpful. So I like this stuff. It is more expensive than its competitor that's made by Premier. Premier makes something called Traxident. Traxident is also a great product. It's a little more affordable, but you do want to use a comper cap, a cotton comper cap, when you use Traxident. Now I got to talk about the really miserable moments. Now, fortunately, for some reason, even though I've done plenty of dentistry that didn't go right, I haven't yet gotten a complaint with the dental board or with an attorney about the dental work that I've done. But I know for sure that if I ever got that letter, I'd feel really crappy. And as an educator, I feel like it's my obligation to be able to convey to you why you would actually get sued. And more importantly than that, when you would actually lose. So my malpractice carrier is a company called MedPro. They used to be owned by General Electric. It was called GE MedPro. At least I think it was General Electric. I don't know. It was called GE MedPro. And I called them and I said, "Can I talk to your head lawyer?" And I was just expecting they would blow me off. And one day later, I got a call from their head lawyer, and he was like, what do you need?" And I was like, "Well, I'm an educator, and I want to teach dentists how to not get sued." And he said, "Oh, that's a great question. Well, I'm not going to tell you how to not get sued. Basically, the way to not get sued is to not be a jerk." Okay, that's great. But when do you get sued where you actually lose? And the answer there is all based on one thing: failure to diagnose. When we fail to diagnose, that's when we get sued, and that's when we often lose. And what do we fail to diagnose? Periodontal disease and oral cancer. Let's talk about oral cancer. For my entire career, when I would go in and do a hygiene check, I would pull a patient's tongue, talk to them about their baseball team and their grandkids, pull their tongue side to side, make them say ah, tell them to lift their tongue up, and then be like, "Okay, well, no cavities, sir. Go on. I'll see you in 6 months." And that's what I would do. The problem is when we pull people's tongues, they don't know why we're pulling their tongues. And so if their lawyer were to ask, "Has your dentist ever done an oral cancer screening?" the patient would say with confidence, "No, my dentist has never done an oral cancer screening." So this is what I think you should do. When you're pulling people's tongue, explain what you're doing. Say, "The reason I'm pulling your tongue is because squamous cell carcinoma, which is the most common oral cancer, usually starts here in this general vicinity. I want to check and make sure that everything looks fine with you." Say what you're doing. And make sure that the auto note that you have in your practice management software has something about an oral cancer screening indicating that you checked and everything looked good. And if you see something that's unusual, take a picture of it with your intraoral camera and be persistent in asking the patient to return in a couple weeks so that you can reevaluate that lesion. Even if that patient calls your front desk team and say, "Yeah, I don't think it's there anymore. I'm going to cancel my appointment." You tell your front desk that they have to be persistent about insisting that the patient come back in. If the patient refuses to come back in, then they need to document that in the communications log on your charting. Okay. The problem is that as we have developed greater technology to do better, more predictable dental work, we now have a greater responsibility to we have a greater responsibility with the incredible diagnostic potential of some of this technology. Now, what I'm showing off here is my CBCT, and I love it. I love my CBCT because patients think it's so cool. And I get to plan implants I get to do guided surgeries with this thing. I love this thing. Here's the problem though. The patients for whom I do a CBCT, they might have a cancer developing, and there's no way I have the type of training that'll teach me how to diagnose any of those things. Here's a sample here. This is I just got this off of a company had sent me this picture. This was a what would this be? An axial section of a patient, kind of going right through their maxilla. And if I looked at that, I'd be like, looks fine to me. But apparently, when it was looked at by an oral radiologist, there was something that was suspicious. The patient was then asked to go get an MRI, and the MRI concluded that they had an adenoid cystic carcinoma. Patient had cancer. The patient was going to die, but fortunately, an oral radiologist saw something odd in the CBCT and was able to save their life. So what happened to me was I didn't want a patient to die when I could have prevented them from dying. And so what I decided to do was find a company that would automatically read my CBCTs. Automatically. I don't want to download the DICOM file and put unzip it or compress it or do any of that bullcrap. I didn't want to do any of that. I just wanted to take the CBCT, look at the CBCT for my implant planning or whatever I'm doing. Just that's all I wanted to use my CBCT for, but then have an oral radiologist swoop into my computer, read the CBCT, and make sure that everything was okay. 2 weeks after I found this company, I was doing, I saw a patient. I wanted to pull all of her lower front teeth, place dental implants, and get her ready for an implant retained overdenture. So I took the CBCT, I took the scan. I was getting ready to make a surgical guide, and then I got a urgent letter from the oral radiologist that was reading my CBCT. And that urgent letter said, you need to follow up with the patient. She has a 2 by 2 by 2.8 centimeter expansile mass extending the pituitary fossa with extension into the sphenoidal sinus. Do you think I know what the hell that means? I don't. But I did know that I should probably refer that patient over to the head and neck cancer department of the Cleveland Clinic. She did. She called me back 2 weeks later. She had a pituitary tumor. The oncologist there recommended that she have it surgically removed, and she actually had that pituitary tumor surgically removed. They found that there was no cancerous spread at that time, and this patient consistently tells me that I saved her life. I didn't do anything. All I did was set myself up so that all of my CBCTs are read by an oral radiologist. I didn't save her life. I just did the responsible thing. By the way, this company, they charge $70 for their radiologist to read my CBCT scans. I'm charging the patient more than that anyway. I don't really care. And it gives me the opportunity to have the personal gratification of saving somebody's life. I do want to share with you this message I got on Facebook Messenger. I got it last summer. And it was from a patient who I saw years ago, way before I had a CBCT, but I did have a panoramic X-ray machine. And we took a pan, and I looked at the pan. I was looking at his wisdom teeth, and I just happened to notice that there were little things that looked like they could have been carotid plaques. And I said, I don't know what this is, man, but you should probably go see your doctor. He left. I never saw him again. Then I got this email about a decade later. Dr. Gupta, I have a story to tell you. Years ago, you did a routine x-ray of my teeth and found a blocked carotid artery in the scan. You told me to go to the ER or my doctor immediately. Everyone was amazed that a dentist caught this. Since then, they put me on blood thinners for 3 months out of every year. And every November, I go in for an ultrasound to check it. Each year, it got better. In November of 2019, I went in and was told your blockage is all gone, but you might need to have this other thing looked at. After some tests, December was 2019, I was diagnosed with HPV, head and neck cancer in my tonsils. I went through the most brutal treatment of 7 chemo and 35 daily radiation treatments. An aggressive cancer with the highest cure rate, 92%. June 25th, I will be celebrating 3 years cancer-free. Doctors told me don't worry about reoccurrence at this point because after 2 years, the rate is very, very low. Since treatment, I live my life to the fullest. I have an absolute wonderful relationship with my wife because of her caregiving. I also have sat back and been very mindful of all my doctors and nurses that have helped me through this. You always pop into my head. Had you not seen the blockage, I would have not had the yearly scans. If I did not have the yearly scans, my stage one cancer could have been stage 4 in just months. I've said if I ever see you around, I live in North Ridgeville, I'd walk up to you, shake your hand, give you a big bro hug, and then cry my eyes out. So if you ever have some weirdo dude come up to you crying and hugging you, now you know why. Thank you, sir. I will always remember what you have done for me. And the most amazing thing about this is I didn't do anything. I barely caught that what I thought might have been a carotid plaque. I didn't have the training. I didn't have the expertise. I was just a little curious, and that little bit of curiosity ended up saving this guy's life. And so, for those of you who have a CBCT, the reason that I'm recommending that you take the plunge and get involved with a company that will read your CBCT is not so that you can avoid getting sued. It's so that you can have the personal gratification of feeling like you saved somebody's life. This company is called Dental Ray. I love this company. Since I have hooked up with them, it's been a little less than a year. Our office has found 4 carotid plaques and 1 cancer. In 1 year, less than 1 year, 4 carotid plaques and 1 cancer. We have been able to encourage our patients to get medical intervention and basically save their life. In my 18 years prior to that, I haven't found that many carotid plaques or cancers. This is such a special thing to add to your treatment repertoire. And then I want to talk about two more things. And I want to start with this X-ray. This X-ray here, I don't know how many people are on this call. You're looking at this X-ray, and some of you might say, "Oh yeah, there's recurrent decay." Actually, about 60% of you will say there's recurrent decay, because this X-ray was shown to about 100 dentists, and 60% said there's recurrent decay. The other 40% said there's fine. And I'm not trying to judge negatively the dentists that say it's fine, because see, I've noticed something. Those of you who are from Northeast Ohio remember this day very well. This was 2016. It was June, and LeBron James and Kyrie Irving and Kevin Love, they brought Cleveland its first national championship in, I don't know, probably 50 years. And I live in Cleveland, and I remember that day so well. And it was a Sunday night, and I stayed up so late just because I was so amped up after the Cavs won. I was so amped. I watched all the press conferences afterwards. And then when I finally did go to bed, I couldn't fall asleep because I was too excited. And then the next morning, I went and looked at X-rays. I was a dentist. And I think it was very possible that I could have looked at those X-rays and I could have missed things. See, because we're all humans, depending on how much sleep we get, what kind of nutrition we get, whether or not we got into a big fight beforehand, if something is stressing us out, if we heard some really bad news, whatever it is, we're going to look at an X-ray and we're going to see stuff that's obvious, or we're going to miss stuff that's obvious because we're humans and we're imperfect. And so very recently, artificial intelligence that basically just discerns between shades of gray in a radiograph has come onto the market, where it integrates with your practice, with your imaging software. And what it does is it just highlights the shades of gray that you might be missing. So here you see a person who has calculus in between their teeth, especially it's obvious on the lowers. They have very incipient lesions on some of their teeth, and they have recurrent decay that's pretty deep on one of their teeth. I can look at this X-ray and I could find all of that, depending if I'm if I'm not in a rush, if I'm totally the conscientious person that I think I am. But what if I missed one of these things? What I like about artificial intelligence is it makes it so that I can look at the x-rays and say, "Oh, okay, oh, wow, there's plenty of stuff here that we need to talk about." Now, I'm not a very aggressive dentist. I would never drill on those small incipient lesions, but I might recommend something like MI paste or, some Prevident mouthwash or something like that, so that those incipient lesions could potentially change. The other thing is patients who are reluctant to understand why they need periodontal scaling and root planing, all of a sudden this makes it very easy for them to see why we're making those recommendations. And then, of course, if I were dumb enough to ever miss a large, obvious cavity, this makes it so that I just can't miss stuff like that. And so keep that in mind. You are a human. You could miss stuff. Give dental software technology and innovation an opportunity to prevent you from missing stuff. Now, I want to end with one last thing. This is an X-ray here of tooth number 18 with a temporary crown on it. Why does it have a temporary crown? I'll tell you why it has a temporary crown. Because I did a crown on tooth number 18 about 10 years ago, and it came off so many times that the patient was like, "Gupta, this is annoying. Do something." So I just basically drilled bigger walls. And as hard as it might be for you to believe, what you're seeing on the screen here, this is actually after I drilled taller walls so that I could have a more mechanically retentive crown. And let's face it, sometimes you just can't have mechanically retentive crowns. The patient's overall crown height is just not tall enough. And in cases like this, you need to use the best possible cement that is out there. Now, for tooth number 19, if that tooth needed a crown, shoot, I could use any crappy cement out there because there's so much mechanical retention. However, as a rule, whenever we cement a crown, we use a dual cure resin adhesive cement. Basically, I use Dual Link Universal by Bisco, and I also use Visalis Semcor by Kettenbach. Why do I use these two? Are they the best cements? I don't know. There's plenty of companies that make dual cure adhesive resin cements. There's plenty of companies. But I like these two for a very obvious reason, which I'll show you in this little movie. So I follow a certain technique whenever I cement a zirconia crown. Most of my crowns are zirconia. The first thing that I do is I try it in. I make any adjustments. Then after trying it in, I use the little air abrasion thing and I air abrade the inside of the crown. This may not be necessary for you. If your lab air abrades the crowns, you don't have to do it yourself. I just air abrade it as a special measure. But this part we always do. We have to remove all of the salivary contaminants inside of that crown. Remember, I tried it in. It's got saliva in it. So we need to use a detergent like Bisclean or IvoClean, any of those detergents that remove salivary contaminants. Then, after rinsing and drying, I use a primer. This is a restorative primer that comes with the kit inside of that crown. And I basically make it so that the inside of the crown will now adhere very strongly to the cement. Now for the tooth. If the patient is numb, I etch the enamel. If the patient's not numb, I generally don't etch anything. If the tooth has been endo-treated, I etch the entire sucker. I just etch the entire thing. This patient happened to be numb, so I said, all right, cool. I'll etch the enamel. I'll etch basically at the margins. So I did. I etched the margins, then I blasted all that etch off. And if you notice, that little class 5 composite that was there at one point had come off. And so normally, what would I do? I'd redo that class 5 composite and redo the crown? I'm not going to do that. I want to use an adhesive resin cement where the resin fills in that void. And so basically I use a tooth primer after etching. And then after I scrub in that tooth primer using the manufacturer's recommended scrubbing time, I air dry, but I don't cure. I just air dry it, fill the tooth with the dual cure resin adhesive. And this is the reason why I love Duolink by Bisco and Visalis by Kettenbach. After seating the crown, I will take my curing light and cure for, I don't know, a couple seconds, maybe 3 or 4 seconds. Now watch this. This is why I love this stuff. Get my Explorer. And, oh, there it is. Oh, oh, isn't that nice? That's why I love this stuff. There are other dual cure resin adhesives out there. But what's amazing about this thing, these ones, is they're so amazingly easy to clean up. That's why I love them. So when cementing, use a dual cure resin adhesive. You are not going to have the same problems that you did maybe when you were using other types of cement. So in conclusion, the stuff that I used, well, first of all, whenever we finish expensive treatment, I always give my patient a water pick. Whenever a patient is gross, I recommend Perio Protect. Anytime I want to check my work, I check it by using the iCam by Shofu. And the etch that I use is the Ultra Etch by Ultradent. My favorite bonding agent for most instances is All Bond Universal by Bisco. However, when I have to bond to a pancake, I will use Peak Universal by Ultradent or Optimon XTR. My favorite bioactive composite is Beautyfill by Shofu, but I know that Vista Apex is introducing a bioactive composite called Regen, which seems to have very, very high marks amongst a lot of the dentists I talk to. I use a diode laser called the Beamer 980, and the gingival retraction paste that I talked about is the Traxident by Premier or the retraction paste by Boco. That company that I was telling you that automatically reads my CBCTs is called Dental Ray, and the company that uses AI to read my X-rays and color in the cavities and the radiographic calculus, etc., is called Pearl. And the easiest, cleanest, most effective dual cure cement for me is either Visalis by Kettenbach or Duolink Universal by Bisco. I want to again repeat that Bisco has sponsored this event. I love their products, but all the other products that I talked about, I'm not getting any type of financial kickback by highlighting my positive experience with them. I only talk about products that I really love in my educational sessions, and I hope that you got a little bit out of this one by listening to me. If you do want to follow me on social, I have an Instagram page and a Facebook page. If you want to just download some of my handouts, you can go to my website, BeBetterSeminars.com, or you can just shoot me an email, and I generally try to respond to them. Thanks, everybody, for listening in. Really appreciate it, and have a great day.